بسم الله الرحمن الرحيم. السلام عليكم. نبدأ الجلسة الأولى. الأستاذ الدكتور أحمد نجا. الأستاذ الدكتور أحمد نجا. الأستاذ الدكتور حسام الوكيل. دكتور وائل. دكتور أحمد نجا ما جاش؟ اتفضل دكتور حسام. دكتور وائل شعلان. دكتور عصام القاضي اعتذر. دكتور سامح اعتذرت برضه اعتذر. خلاص الجلسه هيبقى يبقى كده تمام. ماشي اتفضل. اتفضل. اتفضل حضرتك. دكتور محمد عمر الفاروق. دكتور احمد نجا بس معلش. خلاص اوكي. استاذنا الفاضل الدكتور حسام رشدي اول محاضره. ماشي.
One of the very eminent vascular professor in vascular surgery. His talk is very interesting. He's going to tell us about outcome of endovascular aortic aneurysm repair in patient with friendly versus hostile neck anatomy. Professor حسام.
السلام عليكم. بشكر السادة الحضور على التقديم. الدكتور عمر بيه الفاروق، واتكلم النهارده عن EVAR in hostile neck anatomy. EVAR is widely applied worldwide in the treatment of AAA because of minor invasiveness, lower perioperative morbidity and mortality, shorter hospital stay. EVAR can be performed only in the presence of specific anatomical conditions that are not present in the totality of the patient with AAA. Important in the presence of challenging aortic neck, such as neck length less than 10 mm, neck diameter more than 28 mm, infrarenal neck angulation more than 6 degrees, neck calcification or thrombosis. Manufacturer devised in instruction for use الفاسكوتيك والجور والميترونيك والكوك. اللي بنستعملها عندنا موجوده الميترونيك والكوك استعملناها كتير. اللينس موجوده كلهم مور ذان 15 اللينس بتاع النك. الديامتر اب تو 32. الانجوليشن كله less than 6 degree. الكالسيفيكيشن not severe or less than 50. كلهم تقريبا زي بعض. AAA with favorable infrarenal neck. حضرتك يعني النك موجودة هنا لو قسناها ده favorable neck حوالي 4 سم ونص. الديامتر حوالي 23 ملي. EVAR challenging aortic anatomy في الصورة الأولانية في angulation more than 60. اللينس في النك في الصورة الثانية حوالي 6 ملي. فشالنج في عندنا calcification more than 50% of diameter of the neck. ايه هي الهوستايل نيك؟ short neck, a distance less than 15 mm between the most caudal renal artery and the origin of the aneurysmal dilatation of the aorta. Wide neck, proximal aortic neck diameter of 28 mm or more. angulations, angle of the intersection between lines of long axis of the aneurysm and the long axis of infrarenal neck measurement more than 60 degrees, reverse tapered or conical, morpholic gradual dilatation more than 2 millimeters within the first 10 millimeter of the infrarenal aorta. حضرتك يبقى الدايليتيشن جرادوال في النك، لو في دايليتيشن مور ذان في اول سنتي او تاني سنتي او سنتي واحد ازيد من 2 مللي يبقى ريفيرس تيبرد اور كونيكال نيك اللي هو تبع الهوستايل نيك. نيك كالسيفيكيشن مور ذان 50% كالسيفايد بروكسيمال نيك. نيك ثرومبوزيس more than 50% of circumference of the aortic neck diameters. There is some papers talked about a hostile neck في الإيفار. بيبرز سنة 2008 منشورة في جورنال اوف فاسكولار سيرجري outcome following endovascular abdominal aortic aneurysm repair and anatomical and device specific analysis. In conclusions, application outside anatomical specific IFU variable had an increased negative effect on the late result. Another papers, clinical outcome of hostile versus favorable aortic neck anatomy in endovascular aortic aneurysm repair using modular device. The conclusion, الhostile neck anatomy can be treated with EVAR but with higher rate of early intraoperative type 1 endoleak and intervention. Another papers, EVAR deployment in anatomically challenging neck outside of IFU. Use of active suprarenal fixation and aggressive use of proximal cuff is associated with optimal result. Another paper and another paper, all these papers are talked about EVAR in hostile neck. Our presentation, our cases we did in during the period between 2012 and 2018 with revised prospective and collected and retrospective analysis data 591 patient revised in Bologna Hospital in Italy, Cairo University Hospital, Mansoura University Hospitals. Patients were divided into two groups regarding their neck characters, one who are inside instruction for use and the other for those outside instruction for use. Patient were classified as outside instruction for use if there is at least one item regarding neck anatomy in relation to each manufacturer. Instruction is not full. Early endpoint include technical success, perioperative complication, 30 days morbidity and mortality. Mid-term follow-up endpoint include overall survivor and freedom from reintervention. Each patient was followed up with duplex ultrasonic before discharge and 1 month, 6 months, 12 months, then once annually. If type 1 or 3 endoleak or sac enlargement was detected, CTA were done. Result: there is no significant between two groups in demographic data except age and females. في outside instruction of use p value less than 0.05. البيشنت عندنا في outside instruction of use 202 patient، منهم 162 patient have 1 items of hostile neck، 38 patient have 2 items of hostile neck، 2 patient have more than 3 items of hostile neck. The overall technical success was achieved in 572 patients with no statistical difference between outside or friendly neck. With respect to the proximal neck, technical success was statistically higher in friendly neck more than outside of instructions. Type 1 endoleak was detected in 2 patients of instruction for inside the instruction for use group, 1 converted to open surgery and 1 managed conservative. In 4 patients outside of IFU groups, Patient was treated with cuff insertion, one with fenestrated EVAR and one followed conservative. Intraoperative technical complications, endoleak type 1A, significant in outside of instruction for use. Early 30 days morbidity and reintervention and mortality. Post-operative complication occurred. 8 post-operative complications occurred. 5 in friendly and groups and 3 in outside group, which no statistical significance. 3 cases of early endoleak type 1A, 2 cases in outside of IFU group treated with cuff insertion, and third one in the inside of the group due to graft enfolding, which was converted into open surgery. Survival, Kaplan-Meier of survivors has no significance. Kaplan-Meier of freedom from recurrence, significance in structure outside of instruction of use, low hostile neck. Conclusion, in challenging circumference, patient with hostile neck characteristic can be effectively treated by EVAR outside the instruction for use. If they are unfit for surgery and absent of other endovascular option with accessible outcome in the term of early and mid-term of freedom from reintervention, complication and aneurysmal related mortality. Proper selection and oversizing of the endograft, operating experience and close follow-up are recommended in this institute. Also, adjunctive procedures such proximal cuff insertion are advised for proper outcome. Thank you.
Thanks, my dear colleague, Professor Hussam Rushdi. And now it is my happiness to introduce my dear colleague and one of our eminent vascular surgeons, Professor Tamer Khafagi. He will introduce his lecture titled Epithelioid Hemangioma of IVC, Initial Caster-Directed Thrombolysis, Unmask the Diagnosis.
Thank you, Dr. Hussam, and thank you for the panel. I will talk today about epithelioid hemangioma of the inferior vena cava, initial caster-directed thrombolysis, unmask the diagnosis. The primary vascular tumors are distinctly uncommon and pose a diagnostic and a treatment challenge. The inferior vena cava is an unusual site of the primary tumor development. Several different primary neoplastic disease may affect the IVC, but only 3 cases have been reported to date with epithelioid hemangioendotheliomas. The epithelioid hemangioma has not been reported up to date as a primary tumor of the IVC. The case history, a previous healthy 45-year-old female, no significant past medical history, presented to emergency hospital with epigastric abdominal pain, referred to the back that had developed over a 3-day period. By duplex ultrasound, a well-defined high isoechoic thrombus in the subhepatic suprarenal IVC measured about 2.5 by 3 by 4 centimeter, and there is attenuated IVC part above the thrombus. The CTA demonstrates dilated subhepatic suprarenal inferior vena cava with large hypodense intraluminal thrombus. No extension into renal or hepatic veins could be detected in the CTA. The patient was placed on continuous heparin infusion and taken to the operative room for caster-directed thrombolysis. Despite 48 hours of direct thrombolytic therapy, there was partial patency, and follow-up venogram demonstrated persistent IVC filling defect with a floppy-like sensation felt by the operator when the catheter was directed to this mass. The operator suspected IVC tumor thrombosis, and the patient was then undergoing further assessment. We do another duplex ultrasonography which demonstrated a well-defined mass inside the subhepatic suprarenal IVC with venous flow around. This is the mass inside the IVC, and this is the flow around this mass. We do MRI of the abdomen with intravenous contrast, which revealed dilated IVC with lobulated, smoothly marginated intraluminal soft tissue mass, without significant enhancement in the arterial phase, but it shows a moderate enhancement of the mass in the delayed phase. This is the mass inside the IVC attached to one side, and it is lobulated. Now, what to do? We have three choices: conservative treatment, but this will not get any benefit because the mass will not resolve with conservative treatment. The second choice was PTA plus stenting, but we can imagine this stent will be fractured if it is compressed by the mass. So we choose the surgical excision. The surgical excision of the intravascular mass of the inferior vena cava. Firstly, we do exposure of the dilated subhepatic IVC. The renal veins were dissected also. You can see the IVC and these loops on the renal veins. After this, the mass was dissected from the medial wall of the IVC through a longitudinal incision. This is the mass, how it looks like. And this is the IVC after excision of this mass. Then the incision is repaired through direct repair with transverse sutures. And this is the 6 months follow-up computed tomography and angiography show no recurrence of any masses and patency of the IVC. By microscopic examination, it revealed epithelioid hemangioma, and to our best knowledge, it is the first in the literature to report epithelioid hemangioma of the IVC. Thank you for your attention.
Thank you, Dr. Tamer, for this nice case presentation. Our next speaker will be Dr. Muhammad Omar Al-Farouk. He will be talking about artificial intelligence and aortic disease.
Bismillah ar-Rahman ar-Rahim. I would like to thank Dr. Hadia very much for the kind invitation and with her enthusiasm toward building such a vascular unit. And I'm sure this will be one of the best units that we are privileged to have in Egypt. And hopefully the Congress will be one of the biggest Congress. I would like to share with you a topic which is a little bit recent, which is artificial intelligence in vascular surgery, especially in aortic disease. My content, I will discuss what is really AI and some example, and then how we can use it for aortic disease. Well, artificial intelligence, whenever you have any machine that is developing a way of thinking, like the ChatGPT-3, ChatGPT-4, like multiple facilities that we are using, which imitate humans. So they are not humans, and they are by machine, and this depends on the machine learning. We can see this in, for example, electric car with auto drive. We all have it in our mobile, prediction of your next word. All of this is the basis of artificial intelligence. So we must know artificial intelligence, which is a big category, which involve machine learning, which is a little bit more dedicated. And we have what is called deep learning. And deep learning means network. And network is exactly like the human brain, how it works. And basically, this all can be done online. You don't need to buy a computer. You just need to know a little bit about programming language called Python. And with Python, machine learning is very, very easy. And I will show you what I have done with these multiple level of machine learning. How can this help me as vascular surgeon treating aorta? Well, it's a good computer knowledge, but if you have a clinical problem and then you start to have a vision of a task to be done by the computer, and you enjoy the privilege of a huge data, big data, and then you can do what is called data processing and data mingling, and then you can develop a program to solve your problem. This is the basic idea. So I've divided the AI in aorta into 3 steps. You can use AI tools pre-operative, or intraoperative, or post-operative. Let us take some example. Before you have the patient, can we predict the growth of aortic aneurysm? Can we predict post-operative mortality of open repair? Can we predict rupture of aortic aneurysm? All this is clinical problems, and automatic measurement of aortic aneurysm. So let us take the first one. Machine learning have developed a program that can predict the growth of aortic aneurysm. And you will see here in this gram, this is the actual growth compared to, I'm sorry about this voice. So this is the actual growth compared to the predicted growth. So this program can predict the growth of aortic aneurysm to the nearest 2 millimeter. And this is already found in vascular units. So we can predict. There is already this machine is, this program is present. We can predict also hospital mortality after rupture. This is very nice module, which a vascular surgeon have got 4 risk factors. If you are above 80, if you came with severe hypotension, other risk factor, and with this he made a machine learning program. We call it artificial network. And this artificial network depends on these 4 parameters that he took, and he have a prediction of output which will predict mortality. And again, they found that this program using this software can predict how much mortality. So you can know the patient on arrival. If you have 95% mortality, then you need to really go very cautious. Nothing have reached 100% accuracy, but this definitely give you a light about the case you're managing. Now, this is a beautiful case because here the program can predict rupture. They have found that if you find the amount of thrombus into the aorta and you do modeling, aortic modeling to the thrombus, it will tell you if this aneurysm is going to rupture. This is a patient, you can see in 2017 to 2019, the aneurysm have not changed its size. It is 5.5, but the thrombus has increased. If you do, this was 50, actually less than 5.5, it was 51 millimeter. So if you do automatic analysis with artificial intelligence to the thrombus, it will predict where the thrombus is going to rupture. And this actually what happened to this patient. This patient have ruptured. The red dot is the area where you have the maximum diameter of a thrombus. And 6 months later, he actually ruptured at the exact point that was predicted by artificial intelligence. So it can definitely help you pre-operative. What about intraoperative? Now there is a sophisticated software called CIDR, which has been adopted by Philips and Siemens. And this software can predict endoleak type 2 while you are working, because it reads every pixel in the X-ray, and whenever you have an endoleak type 2, it will give you a special color to the endoleak type 2 that you cannot see with your own eyes, because imaging analysis and imaging acquisition with artificial intelligence, they don't forget any pixel. They see every pixel, and you must know that our resolution, we have 1,200 pixels per cubic millimeter. So the machine learning can see what we clinician cannot see. And this is important artificial intelligence. Now, post-operative, if you put a patient criteria to ChatGPT-3, it will give you the best post-operative follow-up to this patient. This is actually happening now with your mobile. If you just install GPT-3 or BARD or any of the artificial program, and you put the CT scan of the patient, you put the patient history, examination, and you tell him, suggest the post-operative follow-up for this patient, he will give you the best follow-up, how much duplex scan, and when do you need to do the CT scan. So you can imagine this tool is very beneficial. The reason of this lecture was actually, I've been invited to give an AI program to one of the universities in the United States to first-year medical student. So first-year medical student in the United States, one of their things that they are learning is AI, artificial intelligence. And believe me, they are such a very enthusiastic group of medical students because you don't need to buy a computer. You can use Google Colab. And you don't need a big software. It's all supplied free of charge. And you can do all this over what is called the cloud computing. You don't have just a CPU, but you have GPU, which is gigabyte processing unit, and you have a TPU, which is terabyte processing unit. All of this is free of charge. So I have made a free AI program to vascular surgeon that is free to anyone to join. If you just to go artificial intelligence to vascular surgeon Egypt on Google, you will be directed toward this AI program. And I have modified two programs, one which detects COVID-19 in chest X-ray using machine learning, and another one which can detect pneumonia on a chest X-ray machine learning. We are working at the moment on using Python 3 with the what is called Pandas library, which have a lot of machine learning software to develop aortic prediction of the aortic growth of aortic aneurysm. So my conclusion, artificial intelligence will definitely play a major role to us as vascular surgeon. You must use AI tools by today because it is freely available on Microsoft. It is freely available called Bard. On Google, they also have their AI tools, and they are very, they can diagnose a lot of clinical situation. They can read CT scan, they can read duplex scan as well, and they can give you a diagnosis. The ability that AI have is really huge. So I'm sure it will play a major role in vascular surgery field. We can deal with a lot of big data. It can analyze a lot of big data and give you a very good information, and it will definitely improve our clinician and improve our vascular surgeons. And thank you very much.
So the last presentation has been cancelled, and we have 5 minutes for discussions. If anybody has a question for Professor Hussam Rojdi for his presentation. Oh, he's not here. Okay.
I enjoyed your talk very much, and it was very nice paper in collaboration with Italy and other centers. It was very respectable number, which is 500. My question, how much cases has been done in Egypt and how much cases has been done abroad? And definitely I really encourage your work to work in collaboration with them. So if we are maybe 5%, I would be very happy.
About 100 cases that in Egypt and the other in Italy. Cairo University and Mansour University. دكتور محمد حسني كان معانا في الرسالة.
Thank you. And a question for Professor Tamer Khafagi. If you allow me, I want to ask you, I didn't catch that. Did you put an IVC filter before the surgery?
No, we don't use an IVC filter during surgery.
Do you think it has been
actually during the surgery, all the thrombus was lysed. So the only present inside the IVC was the mass, which is lobulated, as you see in the MRI pictures before the surgery, and there is no thrombus during the surgery.
Another question?
Dr. Tamer, thank you for this nice case. You didn't know the nature of the tumor beforehand, before you go into surgery, right?
Yes.
You didn't have a tissue diagnosis.
No, no.
So if we have been confronted with a malignant tumor of the IVC, what would you do? I mean, this tumor was easily separable from the wall of the IVC. If you needed to resect a segment of the IVC and this area was near the renal veins, what would have you done?
This was our fear before this surgery. So we do multiple investigation, all the ultrasound and the MRI, which diagnose that this is a tumor, say that this is benign tumor. And also we do a review for the literature. We see a small number of cases. Most of them was benign, and there is no apparent solution for us to know actually if it is malignant or not. So we go for the surgery, and then we do the pathology. Also during the surgery, the mass looks like benign. So we was not fear to do excision.
Can you elaborate more on the post-operative anticoagulation for this patient?
Yes, we give them the usual anticoagulation as any case of deep vein thrombose. We give them full anticoagulation, especially this patient presented with thrombosis from the start. So we give her anticoagulation for 6 months.
Thank you very much, Tamer, for a very interesting case. I'm sure you have a multidisciplinary decision-making process with this case.
Yes.
My question is, did you consult with the radiologist if he can give you a tissue biopsy before you start using Shigora needle, which is very easily CT guided or MRI guided, because you have indulged over a major surgery without really reaching diagnosis? I will say this because if I got the diagnosis, which is a benign endothelioma, which is very common, why you didn't put a covered stent on IVC to avoid such a major surgery, and you can actually cure the problem? So my question is, you indulged into major surgery before finalizing the diagnostic tools and diagnostic dilemma.
When we do a review of the literature for these cases, we find that there is no large numbers of cases. The most 3 cases, this on maximum. But we find that most of them do stenting at first, and then these stents come with fracture. So they go for surgery. So that's why we don't try to repeat their bad experience. We go for surgery from the start, because about 90% of the lumen occluded by the mass. So if we put a stent, it may end by fracture, as most of the cases in the literature. So we go for surgery from the start because of this.
Another comment, if we have the tumor was actually totally located below the renal veins, we have a distance to do resection and to put a 3 centimeter graft.
It was above the renal veins.
And it was actually
preparing. It was between the hepatic veins and the renal veins. Above the renal.
We was preparing the graft for in such situation. If we have to put a graft and during the resection, you can do.
Your main aim when treating benign is not to put it out. Your main aim is to make it not affecting the IVC flow.
As my doctor or my colleague says that the published literature showed that this tumor actually it grows rapidly. It can cause fracture.
All the cases in the literature end by stent fracture. All the cases. So we don't try to.
How I'm just interested. How many cases has been done with this? 3 cases.
3 cases in.
And maximum. The 3 cases they have put the stent.
Most of the cases are was case reports. Only 1 case or
so
the largest number was 3 cases.
Yeah. So 3 cases worldwide experience.
No. And the largest series was 3 cases, but there is multiple single cases worldwide. I don't.
You know which stent has fracture? Because now we have a stent that will never fracture. The type 2 and 3 generation.
I think by the tumor will fracture anything, and this was their experience. I don't want to try it. Okay.
Thanks.
Thank you very much.
Now, any question for Professor Omar Al-Farouk? I have a question, sir. How did you see the future of vascular surgery in the presence of this artificial intelligence? Are we are going to lose most of our jobs or not?
Good question. This is what we call courtesy question. Whenever you don't have a question to the actual speaker, so the panelist will say, well, I will have a kind question to him. So thank you very much for your kind question. Secondly, well, ChatGPT will fire 80% of jobs in the United States in 5 years. None of them is vascular surgery. So we're not going to be fired. And I think if we are clever enough, we can ride on the tool of AI. I'm quite sure within a couple of years, things will change dramatically. It's already been changed. Now, if you have a CT scan in Dubai, it will be reported by AI. And now AI can diagnose cancer breast more accurate than expert physician. So if you get an expert physician tell you cancer, they'll tell you, I'm sorry, I will just upload the software and then see if this report is right or wrong. Is it going to affect us? In a big way. In a big way. I'm not sure you know that ChatGPT have passed USMLE with 98% success. So now you have the biggest human brain in the world that you can speak to. You can tell him, I have this patient, I have this problem. It will, no question about it, will affect our future.
Thanks a lot. We are shifting now to the second session. Okay. You have a question? Yes, please.
أنا أحمد بعيد يا باشا. أنا في الزمالة الألمانية في السنة الخامسة في الفاسكولار سيرجري. الذكاء الاصطناعي طبعا هيغزو العالم، ولكن إيه مدى احترام الخصوصية، وهل التوجه إن يبقى في عولمة طبية، وهل كل الدول هترحب بهذه الفكرة ولا لا؟ شكرا لسيادتك.
Thank you very much. Germany is really one of the unique educational systems that is adopting a lot of AI. Regarding privacy, they are now putting what is called prompt inside the ChatGPT. This prompt will prevent patient name or face or eyes to come in the reply of a ChatGPT. So here, confidentiality is already been sorted out. You could never reveal patient confidentiality even if you enter the data of the patient with his image. It will be cancelled. Secondly, the big data. Now, all the United States CT scan, ultrasound, and so on is being put into a big data library that we all as a programmer can access in what is called testing our program. So if I got a software that will predict aortic aneurysm, I can go to, for example, Pennsylvania University, to all their aortic cases and do testing module on their cases and get my results. So one of the beauty about AI that all the courses and the data are freely available. At the moment, there is no regulation who has owned what. But we are all working with it. There is rapidly developing. There is actually a group on Twitter, which is in AI, aortic disease dimension development. So you can see how specific things are. So using AI does not reveal confidentiality of the patient. This has been out. Secondly, information are freely available. Thirdly, it will affect our future in a big way, because now the patient will come to you in Germany, in Leipzig, he will go to ChatGPT, tell him, this is my case, I'm going to see physician tomorrow, can you give me the question I need to ask him? So if you don't deal as vascular surgeon with this technology, will be kicked out very easily. But it is very helpful technology. I know a lot of people are afraid of using AI. I use it on my mobile every day, probably 30 times. And I advise everyone to use it at least once per day. Otherwise, you will be outside the AI environment. And thank you very much. It's a very good question.
Yes, we are shifting to the second session, okay? We call the chairman of the second session, دكتور عادل حسيني، دكتور حسين كمال، بروفيسور خالد موافي، بروفيسور تامر خفاجي، بروفيسور سامر رجال.
So the moderator for next session, please come in, Tamer.